5 medical checkups I would never get after 60. I'm Dr. Alina Serratia, and today I want to talk about something that may surprise you. If you are over 60, you have probably been told again and again that staying healthy means getting more tests, more scans, more screenings, and more checkups. And yes, some medical screenings absolutely save lives. I want to be crystal clear about that from the beginning. I am not anti-prevention. I am not anti-doctor. I am not anti-screening. In fact, I believe in smart screening. But here's the problem. After 60, many people start assuming that more testing automatically means better care. And that is simply not true. Some tests are extremely useful when you have symptoms, high-risk factors, or a very specific medical reason. But the same test can become low-value, misleading, or even harmful when it is done routinely, blindly, or out of fear. That is where older adults can get into trouble. Because once you start the chain of unnecessary testing, you do not just get more information. You may get false alarms, extra biopsies, invasive follow-ups, anxiety over treatment, complications, and bills for problems that were never going to hurt you in the first place. So, in this video, I want to share 5 medical checkups I would never get after 60 as a routine, automatic, fear-based decision. And notice my wording carefully. I am not saying no one over 60 should ever get these under any circumstance. I am saying I would never get them casually, automatically, or just because someone told me that more testing is always safer. Context matters, symptoms matter, risk matters, shared decision-making matters. And if you stay with me until the end, I will also give you the one question I believe every senior should ask before agreeing to any test at all. Let's begin. One medical checkup I would never get just to check everything is a whole-body CT scan. This is one of the most seductive ideas in modern medicine. The promise sounds almost irresistible. Lie down, get scanned from head to toe, and catch hidden disease before it catches you. For a lot of people over 60, that sounds like peace of mind. But as a doctor, I can tell you that for a person without symptoms, a whole-body CT scan is usually not the reassuring shortcut people think it is. As we age, our bodies collect harmless abnormalities, tiny nodules, small cysts, benign growths, mild wear and tear changes. These things are incredibly common. A whole-body scan may find them, but finding them is not the same as helping you. In fact, sometimes it creates a new problem. You go in feeling fine, and now you are being told there is a spot on something. Maybe it is nothing. Maybe it needs another scan. Maybe now you need contrast dye. Maybe now someone recommends a biopsy. Maybe you spend months chasing an abnormality that was never going to matter. I have seen older adults lose sleep, money, and confidence over incidental findings that turned out to be medically unimportant. But once the finding appears on the scan, it becomes emotionally hard to ignore. You start living in diagnostic limbo. There is also the radiation issue. One scan may not seem like a big deal, but unnecessary radiation is still unnecessary radiation. Add contrast exposure, repeat scans, specialist visits, and the domino effect becomes very real. So would I ever have a CT scan after 60? Of course, if I had symptoms or a specific reason. But a whole-body CT just to check everything when I feel fine? No. I would never do that casually. Another checkup I would never get, just because I'm older and worried about stroke, is a carotid artery ultrasound if I had no symptoms. This is another test that sounds smart on the surface. The carotid arteries are the major blood vessels in the neck that help supply blood to the brain. So people think, why not check them? What if there is blockage I don't know about? It sounds logical, but good medicine is not based only on what sounds logical. It has to be based on whether testing actually improves outcomes. Why would a test for stroke risk create harm? Because in people without symptoms, these screenings can produce false positive results. That means the test may suggest a dangerous blockage when the overall situation is not actually one that will benefit from invasive intervention. And once that false alarm happens, The next steps may include more imaging, specialist referrals, procedures, anxiety, and sometimes surgeries or stenting decisions that carry their own real risks. In older adults, that matters enormously. Every procedure has a price. Every referral can spiral. Every just to be safe test can lead somewhere you never meant to go. Now, if you have had stroke-like symptoms, mini-stroke symptoms, or your doctor has a specific reason to evaluate your neck arteries, that is a different conversation. But if I were over 60 and feeling fine, I would not walk into a screening fair or clinic and get a carotid ultrasound simply because stroke scares me. I would focus first on what actually lowers stroke risk in a meaningful way. Blood pressure control, cholesterol management when appropriate, diabetes control, exercise, not smoking, sleep, and medication management when needed. In other words, I would rather prevent the stroke risk factors than chase a low-value screening test that can create fear without improving my outcome. A third checkup I would never get routinely, just because I'm over 60 and want proof my heart is okay, is a stress test or screening ECG if I have no symptoms and I'm low risk. This one is incredibly common. A lot of adults over 60 feel a flutter, get nervous about age, or just want reassurance before traveling, exercising, or starting a new decade of life. So they ask for a stress test, an ECG, or some form of cardiac screening, even though they have no chest pain, no shortness of breath on exertion, no fainting, and no specific reason to think heart disease is actively showing up. The problem is that doing heart screening in asymptomatic, low-risk adults is often not as useful as people think. In fact, it can open the door to confusion. If you do a heart test in someone who feels fine and is low risk, the odds of a meaningful life-saving discovery are often much lower than people imagine. But the odds of a confusing finding are not zero. Maybe the ECG looks a little off. Maybe the stress test is borderline. Suddenly now, you are seeing cardiology, getting more imaging, being told not to exercise until more testing is done, or being labeled as a heart patient before anyone has shown that your life will actually be improved by the whole process. And once again, this is where seniors can be harmed by over-medicalization. Not every abnormality needs a cascade. Not every number or blip needs a diagnosis. Not every fear needs a treadmill. Now, if I had chest pressure when walking, unexplained shortness of breath, fainting, worsening exercise tolerance, a high-risk history, or something else clinically concerning, that is different. But if I were simply 65, 70, or 75 and thought, maybe I should do a stress test just to make sure my heart is okay, my answer would be no. I would not do it routinely without a reason. I would rather spend that energy asking, how is my blood pressure? How are my lipids? How active am I? Am I sleeping well? Am I smoking? Am I managing stress? Those questions often tell me more about future heart health than a fear-driven screening test in a person with no symptoms. A fourth test I would never agree to automatically every year if I were a man over 70 is a PSA test, just because that's what men do. Now let me be careful here because this is a nuanced topic. Prostate cancer screening is not black and white. For some men, especially in certain age ranges, there may be a reasonable shared decision-making conversation about PSA testing. But one thing older men need to understand is that routine PSA testing after 70 is not something I would treat like an automatic yearly ritual. This is one of the most important lessons older adults need to hear. Finding cancer is not always the same as saving a life. Some prostate cancers grow so slowly that they would never have caused symptoms during a man's lifetime. But once they are found, they can trigger biopsies, repeated monitoring, fear, and sometimes treatment that creates lasting side effects like urinary problems, sexual dysfunction, bowel complications, and emotional distress. So if I were over 70, I would never agree to a PSA test as a reflex. Not because I deny prostate cancer exists. Not because I think screening is always bad, but because after a certain age, the balance changes. The time it takes to benefit from screening may be longer than the time some men have left free of other competing health risks, while the harms of false alarms and overtreatment become more immediate and more likely. Would I still talk with my doctor about urinary symptoms, blood in urine, bone pain, or a strong family history? Absolutely. Symptoms are different from screening. Risk factors matter. But the phrase, "let's just check your PSA every year because you're an older man," would not be enough for me. I would want a very clear reason. A fifth checkup I would never keep getting automatically is routine cervical cancer screening. If I were a woman over 65 with adequate prior screening and no high-risk factors. This one shocks many women because they have spent decades being told never to skip their pap tests. So stopping can feel irresponsible, but medicine is supposed to evolve with age, evidence, and individual risk. That means if a woman has had the appropriate prior negative testing and does not have high-risk factors, continuing routine pap or HPV screening forever is not automatically beneficial. Why? Because after adequate negative screening, the likelihood of finding something meaningful enough to improve outcomes becomes lower, while the harms of ongoing testing remain real. False positives, unnecessary follow-up procedures, more pelvic exams, more biopsies, more stress, more intervention for abnormalities that may never have become dangerous. And I want to say something important here. This is not about giving up on women's health after 65. It is about being precise. An older woman can still need gynecologic care. She can still need evaluation for bleeding, pain, discharge, prolapse, urinary issues, or other symptoms. But symptom evaluation is not the same as routine screening in someone who has already completed adequate prior screening and is not high risk. So if that were me, I would not continue pap testing automatically forever just because that's what I've always done. I would ask whether it is still evidence-based for my situation. Now, before I give you my final takeaway, I want to mention one bonus example because it fits this conversation so well. If I were an average risk woman without symptoms, I would never get routine ovarian cancer screening with blood tests or transvaginal ultrasound just for reassurance. This is another perfect example of a test sounding proactive while actually exposing people to false positives, extra procedures, and even unnecessary surgeries. That bonus point captures the entire theme of this video. A test can sound smart and still be a bad idea when it creates more harm than help. So what is the deeper message here? The deeper message is not avoid doctors. It is not refuse screening. It is not medical tests are scams. That would be reckless and wrong. The deeper message is this. After 60, medical wisdom is not about doing everything. It is about doing the right things for the right reasons at the right time. That means some screenings remain extremely important. Colon cancer screening may still matter depending on your age and history. Bone density may matter. Vaccines matter. Blood pressure matters. Diabetes management matters. Medication review matters. Vision and hearing matter. Fall prevention matters. Appropriate screening matters. But what I want older adults to stop doing is saying yes to tests just because the word checkup sounds harmless. A harmless-sounding test can carry hidden costs. It can create a label. It can create a follow-up. It can create a biopsy. It can create a surgery. It can create fear. And once that chain starts, it can be very hard to stop. That is why every senior should learn to ask one powerful question before agreeing to a test. Here it is. How will the result of this test change what we do next? I love that question because it immediately separates useful medicine from reflex medicine. If the answer is clear, specific, and evidence-based, wonderful. Maybe the test makes sense. But if the answer is vague, emotional, or based on habit, like we just like to check, or it can't hurt, or because of your age, that is where I want you to slow down. Because age alone is not always a reason for more testing. In fact, sometimes age is exactly the reason we need to be more selective, more thoughtful, and more protective about what we choose to chase medically. I also want to remind you that screening is not the same as diagnosis. If you have symptoms, that changes the conversation. If you have an explained bleeding, chest pain, sudden weakness, severe fatigue, weight loss, shortness of breath, fainting, neurologic changes, or something else concerning, you do not use this video as an excuse to avoid getting checked. Symptom-driven evaluation is different. Family history matters too. Personal history matters. Genetics matter. High-risk status matters. This video is about routine, low-value screening in people who are otherwise asymptomatic or being tested out of fear rather than clinical need. And fear is powerful after 60. People lose friends. They hear diagnosis stories. They know time matters. So they start thinking, maybe I should just test everything. That reaction is understandable. But paradoxically, that fear can push people toward too much medicine instead of better medicine. As a doctor, what I want for you is not maximum testing. I want maximum clarity. I want maximum value. I want maximum health benefit with minimum avoidable harm. That is a very different goal. And let me give you 3 red flags that tell me a test may be low value for an older adult. The first red flag is when the test is being offered because of age alone, without symptoms, without risk stratification, and without a clear explanation of benefit. The second red flag is when the person recommending the test cannot explain what result would actually change treatment. The third red flag is when the main selling point is emotional reassurance rather than evidence. Words like peace of mind, just to be safe, and it can't hurt sound comforting, but in medicine, they should make you pause. A test absolutely can hurt if it leads you into complications, repeated radiation, invasive procedures, or months of anxiety over something harmless. This is especially important after 60 because older adults are more likely to have incidental findings. A younger person may still have some incidental findings, but by the time you are in your 60s, 70s, or beyond, your odds of having something unusual but unimportant somewhere in the body are much higher. That means the danger of overtesting rises with age, not falls. I also want you to know that saying no to a low-value test is not being difficult. It is being medically thoughtful. Shared decision-making means you are allowed to ask questions. You are allowed to say, "Help me understand the benefit." You are allowed to say, "What happens if we do nothing for now?" You are allowed to say, "Is there evidence this helps someone like me?" Good doctors do not fear those questions. Good doctors welcome them. And if you ever feel pressured, here are 4 simple questions I would use before any screening test after 60. Am I having symptoms, or is this being offered only as routine screening? Am I in a group that is known to benefit from this test? What are the downsides if the result is false, positive, or unclear? If this test finds something small or borderline, will I actually be better off knowing it? Those questions can save older adults from a tremendous amount of unnecessary medical drama. Because one of the saddest patterns I see is this: a person who was functioning well gets drawn into a cycle of just one more test, then one more specialist, then one more scan, then one more procedure. And months later, they are exhausted, frightened, and less healthy than when they started. Not because medicine failed them, but because too much medicine was aimed at too little benefit. That is why my message today is ultimately about wisdom, not avoidance. And please remember, low-value screening is not the same thing as neglect. In fact, saying no to the wrong test can leave you more time, money, energy, and attention for the care that really matters. Exercise, blood pressure control, medication review, sleep, nutrition, mobility, vaccines, and timely evaluation when symptoms actually appear. The healthiest older adults I know are not the ones chasing every possible scan. They are the ones who use medicine selectively and intelligently. The right test for the right patient at the right time can be life-saving. The wrong test for the wrong patient at the wrong time can be life-disrupting. Older adults deserve to know that difference. So let me recap the 5 checkups I would never get after 60 as a routine, automatic, fear-based decision. A whole-body CT scan just to check everything. A carotid artery ultrasound if I had no symptoms and no specific reason. A routine stress test or screening ECG just for reassurance if I were asymptomatic and low risk. A PSA test automatically every year if I were over 70 without a serious discussion about whether it still makes sense. Ongoing routine cervical cancer screening after 65 if I had adequate prior screening and no high-risk factors. And the bonus example is ovarian cancer screening in average-risk women without symptoms. What would I do instead? I would invest in the boring things that actually keep older adults healthier longer. I would review my medications carefully. I would manage blood pressure. I would walk. I would lift or strengthen what I safely could. I would protect sleep. I would stay vaccinated. I would keep up with screenings that still offer real value for my age and risk. I would pay attention to symptoms, and I would ask better questions before entering a testing spiral. That, to me, is what wise medicine looks like after 60. Not panic, not denial, not overtesting, just judgment. That kind of judgment gets more valuable with every passing decade. And if there is one final sentence I want to leave with you, it is this. The best medical care after 60 is not about finding the most tests to say yes to. It is about knowing which tests are truly worth your yes.